Good afternoon, everyone. At the outset, I would like to thank AIOS and the scientific committee team for giving this opportunity.
Yes, Sachin.
Well, I think these are the most common cases which are referred to us as retina surgeons, apart from diabetic retinopathies and rigmatinous retinal detachments. Nucleus drops and IOL drops are pretty common referrals for a vitreoretinal surgeon to manage. These, as we all know, could be because of PCR most commonly. PCR can occur at any stage of surgery, especially in cases of hydro procedure. You have to identify it very early. Some signs like pupillary snap, or it can happen during nucleus delivery or a phagophragmentation. This is a video wherein of a PPC which you can see after the hydro procedure. Sorry. After the hydro procedure, as we try to use a phaco probe, you can see the drop which happened immediately after introduction of the phaco probe. So these are the cases wherein we need to assess how to go about, whether you can manage these cases by only the anterior segment, or if the drop is completely gone into the vitreous. See, this is a video wherein vitreous did not come. There was a drop, but anterior hilar did not come into the face. So continued a little bit with the phaco, and then since the nucleus was soft, I used a cutter and managed to remove all the nuclear fragments, did an intravitrectomy, and then clean up all the cortex. The rim was quite good, so 3-piece IOL was placed in the sulcus. So you can manage without going into the vitreous, but you need to assess the situation very carefully. What should an anterior segment surgeon do? If attempt only the retrieval is possible and it is readily accessible, don't try to fish it out. Perform a good intravitrectomy as much as possible. Avoid to insert, if possible, insert the lens based on the capsular support available. This is one more case I would like to show wherein it was a dropped nucleus referred to us, wherein the nucleus was pretty hard. I tried to trim as much as the vitreous, as much as the nucleus possible with the cutter itself, but you can see the nucleus is pretty hard, so I had to bring it out, prolapse it in the anterior chamber, and deliver it to the section by visco delivery. So after doing this, there was enough rim which I could assess, and then I had to place a rigid lens in the sulcus. So most of these cases can be managed very well with if there is a good support, intercapsular support. So fragmentation we can use if the nucleus is very hard in most of the cases, but most of the cases nowadays we are managing it to bring it out in the anterior chamber and deliver it quite easily because of the suction and tools what we have. So IOL options we can choose based on the capsular support. Either you can place a IOL in the bag if possible. You can use iris claw, sulcus IOLs, or scleral fixated IOLs. These are the few pictures of different types of IOL which we can use. This is a video which I would like to share. A case, this was a case of IOL drop. There was enough bag available. So what I did was, once I completed the vitrectomy, it was a foldable lens, so there was a PC support also possible. The rent was in the center. So I brought the lens in the anterior chamber and tried to manipulate it in the PC support itself. It was a foldable, so I had to place it behind the anterior capsule. So it was possible. The same lens was placed. I had prepared it for scleral fixation. If you can see, the conjunctiva was open. So the support, so you can assess and do these cases quite easily. So this lens was placed in the bag, even though the PC support was. So scleral fixation techniques are different ways. We can do either suture technique, which is gold standard. You can do a glued IOLs, or you can do a sutureless techniques. So this is a case which had a nucleus drop as well as the IOL drop. You can see the nucleus was, fragments were there, and the IOL which they had put was also dropped. So nucleus came out with the cutter easily. I'm sorry, the videos are running. So this IOL had to be explanted, and then we had to do a sutured scale fixated IOL. This is one more technique which is a Mahuli technique wherein you don't have to use sutures. You can do transconjunctival most of the cases. This is a case of dropped IOL. Once the IOL was removed, you need to externalize the folded. This is a 3-piece lens. You need to externalize the haptic through a 26 gauge needle transconjunctivally, bring it out. And once you bring it out, you need to, both the sides we need to do this. Once you bring it out, you need to cauterize the tip of this IOL so that it, see, once you externalize it, use a cautery, don't touch the lens. You can make a knob-like things and you can just push it below the conjunctiva. So these are the different techniques which we can use to manage drop nucleus and drop IOLs. Factors influencing the final outcome, of course, are the timing of surgery when you want to intervene, cornea-related problem, glaucoma-related problem, and vitreous-related traction and retinal detachment. Thank you very much. Thank you.
Thank you, Sachin. I have few queries. One is the nucleus drop. You said it was hard, so I will make it an anterior extraction. You could have used fragmentome in that.
Yeah, but then again we have to go through a 20 gauge port. So
one port, hybrid port you can make. Out of the 3, 2 can be still 25 or 23, and one port will be 20 gauge, and you can finish off the nucleus instead of creating an anterior bigger incision.
The anterior tunnel was already there. This was a SICS job. So.
Okay, that was one. The second is the foldable IOL in the bag with a posterior capsular rent, which is a little bit sufficiently for this thing. With time, what happens is capsule shrinks. With that, the foldable IOL gets pushed into the posterior chamber. This happens in the follow-up. I would like to have the follow-up of that patient for a little longer term. The third
captured the optic,
Yeah, optic was captured. Yeah, it was captured. It did not fall. I mean, it's pretty stable, so I left it like that. Otherwise, I had prepared it for an SFIL.
Because it's always a danger. And the third is in MNS technique. If you see the port of the one of the tunnel, this thing, it is very close to your exteriorization of the IOL. Why did you plan that? In MNS technique,
the port is close to the externalization.
Okay. Almost next to each other, which is a little bit awkward while performing the surgery.
Taken.
Thank you very much for your presentation.